Thank you all for joining us today at our 4th annual Global Psychiatry Seminar. Like I said, this event is hosted by the NYCPS and Minority Affairs Committee. Today our speakers are Dr. Shervin Shadianloo and Dr. Ludwing Florez-Salamanca, who have extensive experience working abroad. We will have each of them talk, and I ask that you reserve your questions until the end when we'll have a Q&A session. But if you have any really pressing questions, I'm sure they're happy to take it. So I'll get started by sharing a little bit more information about them. So Dr. Shervin Shadianloo is an assistant professor of psychiatry at Zucker School of Medicine at Hofstra Northwell and a double board certified child, adolescent, and adult psychiatrist. Completed fellowship in child and adolescent psychiatry at Hofstra Northwell School of Medicine. Dr. Shadianloo obtained his medical degree from Tehran University of Medical Sciences and worked as a primary care physician in a rural remote community before moving to Australia, where he was trained and practiced in psychiatry. He pursued his advanced medical studies in New York. In addition to clinical work and teaching, he dedicates his time to working with organizations advocating for mental health of our society, in particular, youth and the LGBTQ community, and to excelling care by engaging other mental health practitioners in education. He is one of the reps to the APA Assembly for NYCPS. Dr. Ludwing Florez-Salamanca is an assistant professor of clinical psychiatry at Columbia University Irving Medical Center and is on the faculty of Columbia University, New York State Psychiatric Institute Public Psychiatry Fellowship Program. He has partnered with different organizations to develop and implement global mental health collaborations aimed at building capacity in Africa and the Caribbean. We will first hear from Dr. Shadianloo and then from Dr. Salamanca.
Thank you very much, and hello everybody. Can you please, the host, can you please make me a co-host that I can share my screen? NYCPS host, can you please make me co-host? Megan and Nelson, oh, perfect, thank you very much. Let me just look here, thank you. Okay. Well, I say hi to everyone. Many names sound familiar, and I think I know many of you. Thank you for coming. Thank you for giving me the opportunity to speak tonight. I know that what tonight maybe shares a lot of experience between many of us who are either immigrants or are working with immigrant people. I thought it's an honor to be able to talk to many of my colleagues here tonight. First, I hope everyone is well, and also I hope everyone has voted or planning to vote. But speaking of it, I thought that I would put my ideas in tubes. I think I'm getting to a couple of different points. One is that as someone who has gone through the process of immigration at least a couple of times from one continent to another one, maybe sort of share a little bit my own experience for others to know that where I am coming from, and also some thoughts about both the differences in working in different places across the world in regards to our profession, as well as sort of a view about at least my thoughts, and the one that I have a little bit looked into, the differences across the border from countries to countries in regards to immigrant patients or working with people from different places than where we are from. A little bit of background where I'm coming from. To be honest with you, I never thought that I would be a psychiatrist. I always when there are a few things that I think I surprise myself more than I surprise others. when I speak to my colleagues, I'm from Tehran. Tehran is capital of Iran. So I grew up, and I was born and raised there. I grew up and I thought that I would be a surgeon. That was what I wanted, or a cardiologist, pediatrician, perhaps. These were all like my top one. And when I graduated from university, I went to, we have to do national health service, but not either go military service or do public health service. I chose to go at a very small little village on the border of Iran and Iraq. And it was an experience by itself. One of the things that I learned was that really people like had a ton of PTSD. This is a section of the country that was occupied by Iraq. They were under rocket for months till it was taken over by Iraq. Then it was taken back by Iran. It became a highly politicized area, 100% Shia. And then next to Kurdistan of Iran, which is mainly Sunni, and so that if you are familiar with the background of Muslims, Sunni and Shia, there is some conflicts there as well. It's a variety of layers. Myself had no clue whatsoever. I think that was perhaps my first immigration outside of Iran, outside of Tehran. I felt like it was left my country and went to a new country. I'm this new kid going there, and they have a ton of rules. That I had no idea about. The culture, the language, everything was unfamiliar for me. That was when I went there, I thought that, well, look, I have been raised in another planet. Like, things are operating differently. Older man would hit the kid if, like, the younger people, if they curse at me. At the same time, I could see sort of like suddenly people would actually hit each other with an axe. Like a younger man came one day, his head was open, like I could see the bone. His father got into a fight and hit him with an axe in his head. They were very expressive in their emotions. And I think partly was also the amount of violence that they tolerated during the war. I think that was my first launching outside of the environment that I grew up in. I was very comfortable. Tertiary hospitals, academic environment, a ton of professors around me. And suddenly I'm going to this little village that everyone is angry at me, that why am I breaking rules? It sort of opened my eyes that what we learn in university is very different to what I'm going to practice later. Now, I was already planning to move, to France, but ended up going to Australia. It's sort of like I'm saying these pieces like in terms of how differently I move. I thought that I would never do psychiatry, but that, as I said, but then I look back, the two things that I surprised myself more than others is that I never knew I was gay at the time. And when I tell my friends, we all knew that. And the second piece that I said, I would never be psychiatrist. Everyone said, oh, of course we knew you would be. You're the only one in the rotation surgery. You were going to spend hours with the patients. You know the family members. You know what was going on with everyone. When I became a psychiatrist, I thought I would never do child psychiatry and ended up being a child psychiatrist. Things that's very interesting develop. And I think it was only because I immigrated and I was able to expand my horizon, learn more and more, and make myself available to things. In Australia, that was one of my first, perhaps, like changes, like to suddenly a new country. Certain things were different, certain things were not different for me. And I was there for 5 years, a very different environment than here. And then sort of like during the time that I was applying for my residency, I spent around 5 years doing psychiatry. I just happened to find this job the last minute in psychiatry, and that's how I ended up becoming a psychiatrist. Even till I applied, I was still applying for non-psychiatry residency. But by the time I was applying, I thought, like, no, I really like this job after 5 years, so I better continue it. At least my experience has been that the cultural shock as the first piece that many of us has experienced, and perhaps is not a bad thing to think about what other either junior colleagues coming may experience as well as the patients may experience, is that there is no one recipe for cultural shock for people. What kind of cultural shock they're going through, even though we're from the same layer of the society, from the same backgrounds. People experience their own shocks in very different ways based on what they shocked. And probably the biggest shock that I experienced after traveling from Tehran to that border town was when I came from Australia to the US. Despite what people think, and I was expecting, when I left Iran and went to Australia, many of the changes were expected from me. When I came from Australia to US, I probably had the biggest shock of my life. So I was expecting two countries similar, speak the same language. I had been to the US several times before, but only as coming and visiting and going back, was that I'm coming from a completely public social system. Everyone has some, like everything is organized in that country. Coming here, capitalism, and the rules are so different. Like the idea that like you can section someone and make them involuntary so quickly was mind-blowing for me. Like it was interesting. When I went to Australia, people asked me, what did really shock you the most? I thought, well, look, you know, actually said, oh, like, is it because women are coming to swimming pools with their with the swimming suits? And I thought, well, actually, no. You know what? They said, what? So your swimming pools, because I said swimming pool. I said, why? Because of the bikini. I said, no, because you're wearing shoes next to swimming pools. I grew up, I was not allowed to even pass by the swimming pool with flip-flops had to be off. We had to clean our feet. Like it was very rigorous getting to swimming pool. Here in Australia, you guys do whatever. We go with shoes by the pool. A piece I think later had a very clinical meaning for me, and working with people sometimes some juniors, sometimes earlier in their career, was that when they entering when they're joining as an immigrant or a new person arriving to the system, was that not to assume what type of cultural shock they're going to have, nor the patients. In fact, I learned it. People coming from my own background, when they coming to the US, they had variety of experiences that were so different than mine. In fact, they shocked me how different they were, or people who had come before different. Language definitely can be an issue. Like not only like I think, but many people would, like I may share that if they're not English speaking person, they can see that how language can be a huge barrier in our field and for our patients. Not only speaking the language, but I think in psychiatry is about being able to express feelings. Feelings mean differently in each language. I can only speak 3 languages like good enough to understand the feelings between Farsi, French, and English. And I realized that each words of like emotions are so different in each language. When we get to the delicacy of the literature around expression of emotions, intimacy, love, things like that, things are like very different in between each of these cultures. Interesting enough, actually, but there are some minor differences even between English-speaking countries. In Australia, things are very different than the US. In my residency, one of the things I experienced was that my friends were thinking that some of the expression I was coming up with, they were different. Going to actually, perhaps one of the thoughts that I had was that psychiatry is a Western developed science. It's not necessarily coming from the Eastern culture. But how much does it apply to, and I would love to hear people who are here, like who are listening, about their experience, how they have connected, if their background is different from a Western culture, as well as sort of like with the people they work with, when they're coming from a society that is not primarily Westernized. Or if it's in the process of being Westernized, and they've sort of like people have had different experiences. How much does it apply? How much doesn't it apply to them, to themselves, and to the people they're working with? But to say this one, and kind of like maybe a little bit mentioned more in the next part around working with people who are from another country. I think again that's the same part without like noticing them. Notice that they without me noticing how similar they are actually of our patients. Notice the same elements come up, such as the language difference in our patients when we see them. Not sure if like I guess perhaps people might speak other languages as you listen. And if you have had experience of doing either therapy or working with an individual who speaks your language different English, did you find the differences? Did you find actually, or did you find the same rules apply? My experience has been that there are certain pillars of psychiatry and psychotherapy in our work that are quite universal. They're not, and we might want to learn them, but then apply them to the culture that we're familiar with, or learn the culture of our patient and apply them. But across the board, I noticed that, at least my own experience from that little village up in the mountains, close to the border of Iraq, with a ton of like experiences of trauma people have had. The same rules apply. Like initially there was a lot of resistance, for example, to boundaries for me. It might sound a little bit silly, but one of the biggest fights I had in the small village was that asking people to come to my office one by one and don't enter my office without knocking on the door. But when I applied it, people actually eventually responded positively, because they noticed that like the boundary of work for them became really important and respected that. The empathy has been so far for me, without knowing it, later I have found a language for what was very interesting and universal across these 3 different continents. And come across, the empathy has been perhaps one of the most important pillars, if not the second pillar of my work with the patients. And these 2 definitely played a significant role, both empathy and boundaries with my patients. I wonder how like people have experienced and how translated in one culture to another culture in their work. But definitely one thing that I noticed is that there are certain things that very much are westernized, and it can become a little problematic if you want to only see them through the lens of the English language or the American culture. We have to have some flexibilities when we see people from different backgrounds. One of the main things that, one of the other things that I noticed, and I'd like to hear from people again if they had that similar experience, is that the experience of patients who are immigrants, we might have felt it in ourselves, but more so I noticed that the people who immigrate, there are some differences between the immigrants and which stage of their life they immigrated to the new country. And that applies, I think, a ton in our work with our patient. One is that I think perhaps everyone knows that, well, the assumption of one person coming from a community that is going to have a certain reaction to get us into trouble. That's like going by assumption, not going to be a good idea. Just because someone, even having said that, I actually often still am hearing, oh, this person is from a Muslim country, and then I'm assuming women are going to respond this way. There is this type of like behavior in their family. And interesting enough, like even patients, they bring up some stuff like, you know, I'm from this country. You should know that. Actually, sometimes I really don't know. How about you tell me more about it? Into a trap of assumption. That's one thing, but there are some stereotypes about each culture. It might be helpful knowing them. For example, knowing, I don't know, I'm from Iran, and there's some stereotype, typical like behavior or cult, like from each part of Iran. I might think that I know them, but I learned something else, is that immigrants are becoming slowly different than where they're coming from. At least the cultures that I'm coming from, mainly I'm familiar a little bit with Turkish culture, as well as like I'm Iranian. I noticed that immigrants do not necessarily match the individuals who live in that country. I've tried to keep my contact very closely with a psychiatrist back in Iran, and to keep updated with what is going on in the motherland and the changes that are coming up. At least the experience that I've had across like the US, there are a million or 2 Iranian immigrants here. They don't necessarily match what is going on now in Iran. They might have left Iran 40 years ago, 30 years ago. And when they left, there was something else going on in that country. That their idea of what is going on is out of tune with where they came from. At least I've noticed that using this piece, working with individuals who are immigrants, at times even first generation, some of the struggles that they come up with in our work was that the parents, for example, their idea had frozen at the time that they left their motherland. And now that they are in the US, sometimes people who are there are way more advanced and way more liberal around certain areas, such as I'm working a lot with LGBTQ population. The world has changed significantly over the last decades. Iran has changed significantly around this matter. Kids and young people are so different now than how they were. But a family that has immigrated many years ago to the US may actually, and the community they live in, might be way more different than what it is there. That was one of the pitfalls, assuming that I know them, that got me into trouble and learned my lesson already. And those are small communities, often I think they develop their own culture that is very unique to the community that they live in. They may have kept certain elements of their own original culture, but they didn't necessarily change them. So that's, is there any questions so far, any comments so far or not? Yeah, I don't see that. Can I continue? So then we'll go to, oops. Why am I, sorry. I thought one of the things that I was thinking about was that we are working now in the era of telepsychiatry. A lot of us, well, if not all of us, I think, we got into seeing our patient through cameras. Some were familiar with it, and some had to become familiar with it because inevitable after COVID time. There are a few thoughts that I had about it. Is that first I was wondering if anyone has worked across the border at this point and everyone has thought about it. People who actually are connected with different cultures. And one of the things that came to my mind is that we have become way more comfortable with using the camera, and sometimes we forget about the legality of matters. It has come to me, like I work with college students who happen to leave the country now, they're all across the world. And the idea was, okay, if I can Zoom with you from New York City, why can't I Zoom with you from across the world, another country? One of the subjects I thought about here is that when we think about the global approach to psychiatry, thinking about how far do we want to expand ourselves, and if people, the ones who are actually working outside of the U.S., like and seeing people and helping people outside of the U.S., how are they navigating that? I'd like to hear from individuals that are doing that. Personally, I have some questions about the risk and legality of it. Taking the risk of doing it is very different, I think, person to person in terms of what you accept. I know countries are different. I know psychiatrists from Iran or some psychiatrists from Europe and psychotherapists from Europe who actually don't feel that it's an issue. And I think legally in their jurisdiction, it's absolutely fine, or there hasn't been any precedence of having issues seeing people outside of country. I know some people who do fit their idea, like their work through not a psychiatric care, but more of a life coach care, counseling, things like that. They changed the name to make it legal. That's another thing that came to my mind. If we're thinking about going beyond the borders, and if we have the experience and connections beyond the borders, how do we bridge that in terms of the legal aspect of our work? I'd like to, I know that I'm a little bit early, am I not, to stop here?
Yeah, we'll have a time to discuss at the end.
Like a little bit, leave some time to see what questions come up, and then we'll continue. See that where the questions are going to take us. I'm going to save some time.
Yeah. Great. Thank you so very much for sharing your experience and giving us a lot of things to think about in terms of how our different experiences as immigrants or, dealing with immigrants. And I definitely have a lot of questions to talk about as we go into the Q&A. But for right now, we will transition to Dr. Salamanca, and I'll let him take it away.
So first, I want to start by thanking the committee and thanking all of you for being here tonight. So as Adjoa mentioned, I work at Columbia University. I'm also part of the faculty of the Public Psychiatric Fellowship at Columbia University and the New York State Psychiatric Institute. And today I will be briefly talking about my experience doing global mental health with Belize through our collaboration with them. I don't have any conflict of interest to disclose. And I'm going to start by telling you a little bit about how and when I started the whole collaboration. So in 2017, I was a PGY4 resident, and I had the opportunity of doing a global mental health track. And I went to Belize for 2 months in partnership with the Ministry of Health and the Global Mental Health Program at Mount Sinai Hospital. And I worked very closely with their psychiatric nurse practitioners and their psychiatrist. The main goal of my collaboration for 2017 was to train the psychiatric MPs to do CBT. After my collaboration, my initial collaboration that year, I am still collaborating with the Global Mental Health Program and the Ministry of Health. I went back to Belize in 2018 and 2019, and for 2020, we are planning a remote collaboration with them. Throughout my very brief talk today, I'm gonna be this concept. This is the Wheel of Global Mental Health, was designed by Dr. Craig Katz and Dr. Schutz-Muller. Dr. Katz is my global mental health mentor. And what's included here is basically different aspects that we need to consider when we are either planning or implementing a global mental health collaboration. There are many things that we need to know about our hosts or partners in the local region there, what types of resources they have, what aspirations and needs they have, and also many things about us as collaborators, what types of aspirations we have and what resources we have. A little bit about Belize. Belize is the only English-speaking country in Central America. It is the size of Massachusetts, but has less than 400,000 inhabitants. So that can give you an idea of how dispersed the population is. It's a very rural country, and of course, getting access to care and going to a town or a clinic, it's very challenging for most of the population there. And also, I think this is important to keep in mind. The GDP per capita for last year was less than $5,000. So that gives us an idea of how dispersed the population is and how limited the resources are. Our local liaison there in Belize is the Ministry of Health. The healthcare system there is publicly funded, single payer system. Healthcare is universal and free. So that has definitely been making our collaboration with them much easier. And first of all, of course, I'm trying to summarize everything here, and it's like a very gross simplification of things just for the sake of time. But I'm going to be talking about some of the resources. Belize is divided in 7 regions, and they have 8 clinics across the country. 1 clinic per region and another clinic in Belize City. They also have 1 4-bed acute psychiatric unit. So you can just picture yourself being an attending in one of those regions, needing to hospitalize a patient in the only acute inpatient unit that's like many hours away from you, and also has a very limited capacity. They also have 1 30-bed long-term unit, but attendants and providers, they really don't rely on this unit because the way it functions is more like an asylum. Patients are there for a very long period of time. The average length of stay is 10 years. Patients are not really getting very active treatment, and there is no expectations for patients to go back to the community. In terms of their human resources there in Belize, in 2017, they had 1 staff psychiatrist, 4 locums from Cuba. So the government of Belize has an agreement with the Cuban government, and every 2 years, the Cuban government sends 4 different psychiatrists that will be working in Belize for 2 years at a time. That makes it difficult to train them because, of course, they are there only for a short period of time. And also, many of them don't speak English, even though English is the primary language of the country. As you will imagine, it's very difficult to have access to an interpreter or a translator. That definitely makes clinical care more complicated. In 2017, they also had 13 psychiatric nurse practitioners. They are the de facto providers, mental health providers in the country. They all trained together 15 years ago. Their training was 1 year training after nursing school, and they didn't have clinical rotations. But as soon as they graduated, they started working as psych MPs. In 2017, they also had one psychologist and one social worker working for the whole country. And in average, for each one of those clinics that I mentioned before, they had between 5 to 6 primary care doctors. The aspirations of the Ministry of Health for 2017 collaboration was for us to train all the psych MPs to provide CBT, and that's the request that they had for the collaboration. Their main focus was CBT. But when we were there, of course, we were doing a needs assessment, and every time we are doing global mental health, that's something that's very important for us to do, not just at the beginning of the collaboration, because the needs assessment, it's a dynamic and an ongoing process. So even after we were already there, starting to implement the collaboration, we were doing the needs assessment. And for 2017, we realized that actually the psych MPs were not interested in doing CBT, and they didn't even have the time to provide psychotherapy. That, of course, challenged our aim and our goals for the 2017 collaboration. During our work with them, we also start realizing that they had many knowledge gaps. I can give you a few examples. One day, I was seeing a patient with a nurse practitioner, and it was a very clear case of PTSD. So after the patient left the PTSD, she looked at me puzzled and she said, "Oh, what's that, doctor?" And I told her, "Post-traumatic stress disorder." She started giggling and she just looked at me and said, like, "Oh, don't worry, doctor. We don't have those things here in Belize. That only happens in America." It can give you a sense of the training they received and the type of care they were providing to the patients. Another thing that we realized when we were there in 2017 was that many of the patients were diagnosed with psychotic illnesses, even though they didn't have psychotic symptoms. And many patients were prescribed one first-generation antipsychotic, one second-generation psychotic oral, and one first-generation long-acting injectable. All of them at the same time, all of them at subtherapeutical doses. And the rationale for doing that was that if they were prescribing the medications at a lower dose than the recommended one, then they were decreasing the risk of side effects. Of course, patients were not accurately treated, and I think one of the reasons why that was happening was because we also realized that they were actually not doing any monitoring of symptoms. Patients will go to the clinic every month, get the injection, get a refill of the medications, but the MPs were not really asking about current symptoms and side effects. Another need that we identified is that they didn't have continuous education, and as you will imagine, they didn't have easy access to resources and information. I think we can all agree that with 13 nurse practitioners and 4 psychiatrists for the whole country, and more resources. So what were our aspirations as collaborators? We definitely wanted to build their capacity and advocate for more resources. And the resources we had as collaborators for 2017, well, the Institute at Sinai has residents and attendings that are willing to teach and supervise the psychiatric nurse practitioners. And Mount Sinai was sending a group of 1 resident and 1 attending psychiatrist every year to spend a month in Belize working very closely with the psych MPs. But those were very much the resources we had. So of course, after considering all their resources and their needs and their aspirations and our resources and our aspirations, we developed a strategy. And in our strategy, we wanted to focus in task shifting, capacity building, and advocacy. So first of all, why task shifting? I think we can very safely say that to provide mental health care, given the huge shortage of providers that they had, that So we thought that it was important to help the primary care doctors and have the primary care doctors identify and treat common mental disorders, increasing access and supporting the efforts of the mental health department. Also, as part of the task shifting, primary care doctors, we thought that it was important for them to collaborate with the psych MPs for more complex cases. So I told you before that there was only one acute psych unit with 4 beds. Many times the unit was full, or the patients were needing psych inpatient care, but they were very far from the capital city. So many of those patients will end up being hospitalized in the medical inpatient units. And of course, that made the need of having the primary care doctors stepping outside their comfort zone a little bit more and doing this task shifting more relevant and more important. If you think about doing task shifting, and if you just imagine how comfortable the primary care doctors felt with providing psychiatric care for some of their patients, of course, the first idea is doing the task shifting, but then the other thing that needs to follow is the capacity building. And the way we have been doing capacity building for the primary care doctors is through seminars and disseminating materials, specifically the image gap. The image gap was designed by WHO. It's a program that specifically target to primary care doctors to help them provide primary care mental health care. So the model is a very, very nice model, very comprehensive, and trains primary care doctors to be able to provide care for the mental health needs of their patients in the same clinics where they're working. And we also have been trying to foster the collaboration between the psych MPs and the primary care doctors. But if we were going to build the capacity of the primary care doctors, we of course also needed to build the capacity of the psychiatrists and the psych MPs, because they were going to be the specialists in country and they were going to partner with the primary care doctors. And we have been doing that through seminars, disseminating materials, on-site supervision, and also as needed remote consultation. As I mentioned before in our strategy, one of the things that we also wanted to do was advocacy. And we did advocacy at we're currently doing advocacy at 3 different levels. One level was the mental health department. We wanted to have more time allocated for the MPs for their continuous education and more time to foster our collaboration with them. We also did advocacy at the Ministry of Health level. We were in conversations with the ministry for them to train more psychiatric MPs and also allocate more resources to pay for those salaries. And we also partnered with FAITH. FAITH is an NGO that's run by family members of people living with mental illness. And they're basically raising awareness about mental health conditions in the country and the lack of resources and proper treatments for their loved ones. So I told you before, I went to Belize in 2017, then I went back 2019 and 18. And during my last 2 trips, it has been very nice to see that actually there have been improvements in the delivery of care that patients are and the services that patients are getting there. So last year, the Ministry of Health went ahead and trained and hired 18 new psychiatric nurse practitioners. That's definitely a huge improvement in the number of providers there in the country. FAITH is also a very active organization and has been putting a lot of social pressure on the government to allocate more resources for mental health treatments and facilities. And even though we don't have hard data on this, from our experience working with the MPs, we have been seeing improvement. So I went back to this same clinic where I saw this nurse that was not aware of PTSD as a diagnosis, and we're seeing a patient, once again, a very clear case of PTSD. And she got all excited and she was like, okay, so I'm gonna ask all these questions. And she then was telling me like, this is PTSD because of this and this and the other thing. And she was telling me like what she was planning to start and how she was planning to treat the patient. And she also was telling me about other patients that she had been treating on her own for PTSD. So that was definitely a very nice surprise. And also through my direct work with the MPs and also reviewing charts, we realized that the polypharmacy has been decreasing significantly, and they are now focusing on optimizing monotherapy first. Which was our next steps. We definitely want to continue supporting and training the new psych MPs. We feel that if we have an opportunity to better train and to be able to improve the mental health care that many patients will be getting for a very decent amount of time. And we also want to develop and implement remote supervision and consultation. And that's what we are working on for the 2020 collaboration. Thank you very much. That was a little bit about my experience with Belize doing global mental health. Of course, as I mentioned before, a very summarized version of it. But I'm happy to take questions and talk about this a little bit more.
Thank you so much, both for Shervin and Ludwing. Those were both great presentations, and I want to open it up to anyone to turn on their mic and ask a question to either of the presenters.
I want to ask a question from Ludwing. I'm waiting for you to come back. Oh, there you go.
Yeah, sure. I'm happy to take the questions.
Thinking about, I had a question, and mine is that, like, you applied some of the good practice of psychiatry to a small community that functions based on their own culture. I imagine then some elements of that culture like had to be manipulated to change and adopt. And we know that at times people, especially with chronic mental health issues, they form what they've been molded into, unfortunately, even if it's a pathological diagnosis, also, and not even if it's an inaccurate diagnosis as well. My experience has been that when you try to shift, I have never worked in a small country like that, but was that when you try to shake the system, it's not only the resistance that comes up, sometimes actually people decompensate badly because unfortunately their defense systems have adopted into the role that they have played for many years, even if the initial diagnosis wasn't that. I was wondering if you had any experience about how it worked out when those changes happened.
Yeah, so that's definitely a very good question. And when you are partnering with a local organization, and I think it's very important once again to emphasize in that word partnering, right? You are working very closely with them, and they are the experts in their culture and their way of providing mental health services. So our goal was not to go there and just implement an Americanized way of providing care. It was more going there and working with them in identifying potential ways of improving the way they were already providing services. There are some things that, of course, and every time you're doing global mental health work, there is a lot of controversy, and some people say like, oh, but you go there with our American DSM diagnosis and start working with people there. And I think that will lead to a way larger discussion. What I just wanted to emphasize is that it's not us going there and imposing or not being mindful and respectful of their culture. It's just a collaboration with them, and we basically just try to help them identify some gaps in their services and find ways of helping them improve them. But of course, with their resources and with their aspirations, what they think it's more relevant and more important for them.
Thank you. No, very good point.
And for Ludwing, I was wondering why, I don't know the number of doctors that they have overall in Belize, but why was there only one? Was it that people in their medical training preferred other specialties? There's a stigma about being a psychiatrist, like in so many other countries, or what was the reason for the low numbers?
Yes, and that's once again a very good question. I would say it was definitely multifactorial. They don't have residency programs in the country to train psychiatrists. So most of the primary care doctors that want to be trained, so they're all first trained as the general practitioners. And after some time, they go ahead and pursue more training. If they want to do it, then they need to go abroad. And most of them will end up staying in the other countries, right? Because the other countries will offer better quality of life and better job opportunities. So yes, definitely Belize also is not able to offer very competitive salaries. And most of their doctors, if they have the opportunity, they will prefer to work abroad.
And are the physicians from Belize paid by the Belize government to train abroad for specialty training, or they go and they fund that themselves?
Yeah. So one of the biggest challenges we had during our collaboration was getting the government to agree to train them. So how, like at least with the Psychiatrist, how it works is that they are already hired by the Ministry of Health. They went to nursing school on their own. They were hired by the Ministry of Health, and then the ministry allocates time and resources for them to go abroad for a year, get trained, and go back to the country and work there, right? And the same thing happens with the general practitioners, with the primary care doctors, right? So that's also another limitation there. The Ministry of Health doesn't have, and they need to prioritize very much what type of specialists they're going to train. And it sounds like they didn't have much psychiatrists, but the comparison with the number of pediatricians or surgeons or OBGYN providers was not very different.
Okay. And then another question I had was, what is the scope of disorders that a psychiatrist treat? Because I know in other countries, sometimes you're almost functioning as a neurologist. That was my experience in Ghana, at least. Or your psychiatrist was kind of there's only one psychiatrist, but the psychiatrist was almost like the primary doctor, or the NP was the primary doctor for everyone. And I know they're trained kind of in a general base, but is it sort of like that there, or is there good access to follow-up specialist care in other domains?
Yeah. So you can just imagine, right, a country with such limited resources and such limited access to mental health services. Of course, the providers, the patients, and the system are focusing on those patients that are more acute, that can be perceived or more disruptive in the community. So definitely there was a heavy emphasis on patients with psychotic disorders, with bipolar, with problematic substance use problems. Mm-hmm. The psychiatric MPs were seeing some patients with more common mental illness, but I think shifting the task of the primary care doctors and building the capacity on treating common mental illness definitely increased access to care for many of those patients that were symptomatic but were not being identified and treated.
Okay. And I also see that we have a question in the chat for Shervin from Dr. Kostakis. She mentions that she's active on being an immigrant and being invested in global mental health, and that it seems to be a common thread among our presenters and myself. Why is that? Has it helped you in your work in global mental health being an immigrant? And this is a question to both presenters. Essentially, has being an immigrant helped you in your work?
Ludwig, you want to go, or should I say? What? I think for me, definitely, it's the same as it's
Ask
not.
you. I'm happy to go first or after you.
Sure. What I would say, absolutely. Like it's I don't think it's necessarily needed. Similar to many other things that people investment in a subject, and being an immigrant, I think by itself and the process of immigration creates certain experience and certain investment. At least for me, definitely was. One of the thoughts that I had, which hasn't fully even crystallized, was that how to include and how to involve, like to cross the borders across different countries and engage people more into it. I think being an immigrant and being a minority by its own way was one of the main reasons that made me interested more in the things that I'm minority in. That's probably that's the main reason also I became more interested in LGBTQ care. I didn't think I would. I thought, well, like, that's my experience in the beginning. But as I started working, I realized that all of these things that are interesting happened for me, that after I started working, I realized that these are the areas that I have had my own journey, and then it started making sense that to invest more in them. Thank you, Anna, for asking it. And I think perhaps it seems to be the case across a variety of subjects, but not always. Like prenatal care often is provided by women rather than men. Does it mean that a man cannot do that? I don't think at all. I think it means to sort of primarily people have some investment, some understanding of it. Mm-hmm. The same as I think allies can very well be very good LGBT.
I feel for me, there is definitely a component of giving back. I'm sorry, there was some problem with the connection.
I think there is a delay, and when I spoke, then you got it later.
Yeah, so I feel that for me, there is definitely a component of giving back to a community that feels closer to home, closer to my roots and where I'm from. And I don't know, I feel just passionate about us. There is definitely a component of huge motivation coming from a country that struggle in providing appropriate services. So I don't know, it's just like if I see something that can be improved, there is definitely that desire of helping and giving back.
I don't want to monopolize the questions. I do have one more question, but I wanted to give everyone else a chance if anyone has any other questions.
I'm going to make a very quick comment on what I said. I think, but they're not always, these things are not always without barriers. One of the major obstacles that I hit was political agenda between the two countries. I realized living in the US and with the political climate in Iran, I had to really back off, mainly work with transgender individuals. The work is happening in Iran, but when I started getting myself involved and working with people within the clinic in Iran, then I got noticed, well, hey, if you become very known, just going back and forth between the two countries, that can get you into trouble, and you can become a target of politically being picked. So I started going more into shadows and not working more on that, unfortunately. So these things can also happen. It's unfortunate, but it can happen.
I have a question. So thank you for both of you. I just wanted to ask something, sitting here as someone who's going to graduate in a few months. I am wondering about, what is your advice to people who are kind of going to start looking for the next job and they're interested in global health? Because it seems from my experience, from what I've seen, it's predominantly kind of another interest that's on the side. Is it something that usually you kind of build up later, or is there pathways for people to kind of do predominantly global health?
Yeah, I can go first. So I feel like it definitely depends on what type of focus you would like to give to your career. There are many programs that help people interested in doing global mental health work trained and get to more like full-time positions, let's say. But those programs are more towards research. So if you see yourself as a researcher and you are interested in devoting your career to research and like full-time work in global mental health, there are definitely very good programs here in the city and in other big hospitals and big universities in the country that focus on that. But just keep in mind that it's very research oriented. Otherwise, it's very much what you described. This is not my full-time job. It's just something that I do as a side.
Like one more thing is that you have to accept, I think if you want to work globally, you have to accept that you may, if you really want to do clinical work, there are organizations that you can join and work with them, and many of them are working across different countries and they're looking for physicians to work and definitely psychiatrists to work. But you have to be ready, especially as a child psychiatrist, Sally, you will be very much wanted, I think, in many different countries and with kids, but you also have to be ready to leave and go and work in other countries if you want to expand your horizon to those cities. It is a fascinating job, and there are many organizations who are available to do those type of clinical work, but you also have to be ready to leave and pack and go. With telepsychiatry, that's a good question, and I'm wondering that if there are some that will be able to add, like to create component of your work. Being a psychiatrist is very easy for you to have like 3 or 4 different jobs at the same time. And you are bilingual. I think one of the things, perhaps if you're interested, you can look into is that are there local organizations in the areas that you're interested in, or from the homeland, or from the areas that are in need, that you can partner with and work with them depending on how the local licensing is going to work for you or for those organizations, that you can work remotely with them. That's another thought that I have as well.
And my last question, sort of to piggyback off of that, is for Shervin, was about, you did your graduate, training in psychiatry in Australia. So I was just wondering if there's like still an element of practice that you're somehow able to do with the local licensing in Australia. You mentioned also still doing work in Tehran or in Iran. So just sort of how that looks like, I guess, with the rules. Is it something that you do with telepsychiatry? Is that you go over there for a period of time? Are you perhaps working through an organization or have a practice independent there on your own?
Sure. With Australia, when I left, I stopped and I didn't renew it and I didn't continue. It was only the work that I had in Australia. They're in some way very different. It's a British style of training. Not like you can have an endless years of training, and then unless you do the fellowship exam, then you don't become a psychiatrist. So it's a very open-ended type of training and assistant training rather than residency condensed training. Back in Iran is still a licensed physician, and I kept my connection with Iran. The main thing that I did maintain my work back home has been with the only area that Iran still has been pretty active around transgender care, and they're a true finding people and the psychiatrists there. Found one of the clinics in Tehran that has actually become the main registry and center for caring for transgender individual in Iran. So I worked with them and connected with them. Every time that I was traveling back home, I would meet with them and talk with them. That has sort of come to a little stop. I don't know if the barriers from their end or my end. That's what I did. One of the things we were thinking was that actually cross-culture, looking at the elements of gender identity, is it culture dependent or not? Really, one of my interests was that understanding the development through the lens of different cultures. I think people develop in some way neurobiologically the same, but another way based on the language and the culture differently. And gender is significantly influenced by the culture. Understanding through an open-ended investigation of individuals was that I couldn't paralyze it with one individual. But I haven't been able to do that in terms of comparing people in their narratives of like development across the two of them. That's how I found it. Mine was actually by going back, going back to my medical school and finding my connection and connecting to people there.
Okay. Very nice.
Thank you.
Well, I would like to thank both Shervin and Ludwing for speaking. Thank you so much for sharing your candid experiences of work abroad and your perspectives, and it gave a lot of things for us to think about. And thank you to everyone that attended our program today. I would also like to thank the Professional Risk Management Services for sponsoring our event this evening. And then I'll also make a plug for the Minority Affairs Committee. If you're interested in joining us, please feel free to reach out, or any NYCPS committee. We're, committed to just increasing more dialogues and conversation about our experiences here, locally in New York City, but also internationally and nationally as well. So if there are no other comments, I'd like to say thank you and have a wonderful evening.
Thank you, everyone.
Thank you.
Thank you. Bye.
Bye.